looks like many of us are here, so we will go ahead and get started with our November learning session. Thank you all so much for being here with us today. Um, we appreciate it, especially during this busy time. Thank you to our Best for All operations team for the guidance throughout this project. Always appreciate their expertise and counsel. And of course, thank you to our teams, all 23 teams throughout the state for all your hard work in this project and continuing to work and provide respectful care for all patients. We've got a great learning session scheduled for today. After a brief welcome from our project leads, Dr. Skedzina and Dr. Lister, we'll hear from Amy Pedraja on respectful care for Spanish-speaking patients. She will take us through a cultural toolkit that will leave teams feeling a little bit more knowledgeable of the Hispanic culture and ways to support Spanish-speaking patients in the healthcare setting. With Spanish being the second most prevalent language in Tennessee, we wanted to provide all our teams with another tool in providing respectful, patient-centered care for all patients. Finally, Bonnie will close us out with a few upcoming events and announcements. So I will turn it over to Dr. Lister and Dr. Skedzina for our welcome. They may not have been able to join just yet. So this is my official welcome to all of you teams. Thank you so much for joining us today, and we are so thrilled to have Amy here. It's my pleasure to introduce Amy Pedraja. She was born in Chicago to Cuban immigrant parents who arrived in 1954. She's a medical interpreter with the Tennessee Language Center and a graduate of Trinity International University with degrees in psychology and communications. Much of her career has focused on leveraging her Spanish language skills and educating others on cultural nuances. As the manager of a cultural diversity department for a major banking corporation, she traveled across the U.S. training sales staff on culturally appropriate marketing to the Latino community. Passionate about bridging communication gaps, Amy enjoys her work as an interpreter, fostering understanding through language. Today, Amy joins us to enhance our understanding of the Spanish-speaking community and explore strategies for addressing cultural differences in healthcare, all in support of the project's goal to provide respectful and the best care for all patients. Welcome, Amy, and thank you for joining us here today.
Thank you for having me. I really appreciate it. So I hope I can contribute something to the session.
Absolutely.
Mm-hmm. Okay, so today we're going to talk a little bit about cultural nuances in the medical profession. And first, I wanted to mention that everyone is different, so you won't see the same each time. Sometimes you expect that every single Hispanic or Latino patient might have the same cultural references or habits, and it really is person to person. It's based on where they come from, how long they've been here, how they've acclimated, what their family history has been like. So that's always important to note. Quick story. I worked for a major bank industry, and I had to train people on how to deal with the Latino community. Part of that was finding Latino staff members in the banking industry to assist with that initiative. And the reason I stepped in is because management was unaware of different nuances, and they picked people to be part of a sales initiative to Latinos just based on their last name, without understanding that not everyone with the last name Garcia may know nuances in their culture or even be Hispanic. They just have the name. So important to just something to think about. Next. Okay. Traditionally, you'll find people with very lengthy names. Typically, their names consist of their first name, sometimes a middle name, and then their father's last name, and then the addition of their mother's last name. In the office, typically we look at the very last name, and sometimes they respond to that. Sometimes they don't, because we typically respond to our father's last name, if that is what we associate our names with. Um, I grew up with a lot of my parents' friends using a different method where we used our mother's maiden name and then de la and father's name, which is probably not appropriate nowadays because it means I belong to um, the husband's name. So there's different derivatives of how people um, have their names written, and they can be very lengthy. So it's just something to note that you're going to find a lot of names with different patients, just the way it is. Next. Oh, just like I said, the second last name comes from the mother. So the mother's name comes after the father, typically. And here is just an example of that, where you have the father on the top, Antonio Hernandez Vargas, and Vargas is his mother's last name, and Hernandez is his father's last name. And then he marries Maria Rodriguez Lopez, and Rodriguez is her father's last name, and Lopez is her mother's last name. So they two get married, and they decide to name their child Jose Hernandez Rodriguez. So no middle name in this case. Hernandez is the father's name, and Rodriguez is the mother's last name, and the surname, which is her father's last name. So that's what's typically done. Next. Another huge part is Latino families have a huge family connection, very, very tight. Um, I've witnessed patients coming in with up to 6 or 7 family members for an appointment, which can be overwhelming to some who are not accustomed to that. But it's fairly typical that everyone is part of the decision making when someone is ill. Um, I've also seen that sometimes when there's a case of someone being extremely ill or an elderly, the family comes because they want to take in the information and not necessarily let that elderly person know exactly what's going on. But that's a side note. But the family is very much involved in healthcare decisions. Next. In religious beliefs, I have found, and in my own family as well, is we have very strong religious beliefs. Many Hispanics or Latinos are of a Catholic background. I know I grew up Catholic. I'm not anymore, but I grew up in a very Catholic family, and I see a lot of patients that have a very strong affiliation with the Catholic Church. And during their appointments, they're always referencing their faith, that it may be God's will or whatever the case might be. They bring up faith as an important part of their health care. So you'll hear statements like this. So thankful to God, or maybe it's God's will, or only God knows, or we're in God's hands. So that's what these statements say. But it's very important to them to include their faith in their decision making. And whether it be good news or bad news, they always feel that it is God's will, whatever happens. Next. Next. Okay. The pain scale. This is really interesting to note. I know this from personal experience in my own family and from what I've seen is Hispanics, Latinos are much more dramatic. And maybe you've come across this, where the pain scale has to be really clearly defined, because even a slightest type of pain could be considered to them a 10 just because they're dramatizing. And I've seen that over and over again, where the pain level scale is just off the charts. And it could be something minor. So it's just something that has to be really clarified. And I try to make mention what exactly each number means so that it's more accurate to determine for the medical community what that patient is going through. Short story, I once had an oncology patient who was asked at her second chemotherapy appointment what her pain scale was, and it was off the charts. It was like 9, 10. She had terrible side effects. It was horrible. She was just wailing how painful and how much discomfort she had had for the previous week since her last treatment. And so they decided to lower her treatment dosage as a result. And I could see her wheels turning suddenly, and she seemed kind of happy about that. So the following visit, on her third chemotherapy visit, she decided to do the same thing, thinking that her dosage would be reduced again. But instead, what the staff then determined was to tell her that they were going to change her course of chemotherapy to different drugs altogether. And she realized that it backfired. So that's why it was so important to explain to her what these pain scale levels and numbers mean, because it's for her betterment than just trying to manipulate the situation. So that was very key, and that got straightened out. But the pain scale can be off the charts if it's not really defined what 0 means and what 10 means or what 7 means. So it's very unique to see the drama, and I've seen a lot. Next. Medications. Typically, and it depends on socioeconomics, it depends on education, it depends on history, it depends on where a person is from. Some people are very adverse to taking prescription medication because they feel that it's not natural. Many indigenous clients refer more to herbs and ancient remedies. They may self-medicate. They may be very adverse to prescriptions because they're unaware of how they work, operate. So it's really key to understand that they're going to bring this subject into the appointments. I've seen it a lot where they're offered certain medications and then they will offer themselves what they can provide to different treatments. You know, can I take X herb? Can I take, you know, this vitamin? Can I take this? Some countries have more flexibility with making antibiotics more available, and they will self-medicate, which could alter their treatment plan. So there's a lot of different variations on how they see their treatments versus how we see our plans.
And like the
So I'm sorry, was that a question?
I think someone was just joining.
Oh, okay. Okay. So when it comes to medications, you may hear a lot of differing opinions about herbs and different alternative treatments. And it can affect how they think about prescriptions or how they may adopt taking a prescription from a doctor, because there's a little skepticism oftentimes with prescriptions because it's an unknown. Next. And here again, we're talking about herbal remedies and diet are very important. Oftentimes, I've gone to appointments where they are offered a prescription or they're told a diagnosis, and immediately the patient will ask, can I take, I don't know, turmeric? Can I change my diet in any way? Um, and they have healers that they go to, and they have different ways of treating different diagnoses. It's just something that has been passed on from generation to generation. Very, very common. Um, Even I know for myself and my family, my dad rubbing alcohol when I had a fever on my back, just things like that. Just very natural. Doctors took second place to just healing at home. So it's very common to hear that they want to be a part of the healing regimen in some way. Go ahead. And again, they're very hesitant, I've seen, to use pills. Why is somebody calling? Oh, sorry. And I'm sorry, something happened to my phone. Very hesitant to use pills, very hesitant to use prescriptions or be told that they need to take something for a certain time. I've seen patients who will accept it and then they don't follow through with taking their medications. So at their follow-up appointments, they may say they just didn't like it, they felt funny, um, just because it's just very unfamiliar to them. And that's very, very common. Next. Here we see a lot of indigenous languages also. I'm not sure how frequently you may come across them, but I have come across several of them. Um, and it's just different forms of communication that you'll come across where they don't necessarily speak Spanish, but they speak a derivative of it, an indigenous language that is really not Spanish. And so in my case, I've had to have an interpreter for myself to interpret what the patient is saying because I don't know personally any of these indigenous languages. So patients will come in with differing dialects, and you need somebody to help figure out what exactly is being said because it's not always just Spanish, especially as shown in this chart. Preventative care is a very foreign concept to many families. I have seen patients where they come in for something specific, and they don't have a PCP because it's very foreign to have a primary care physician. Typically, they see, if they're pretty recent and into this country, they see one doctor who takes care of everything. Um, if you have a scrape on your knee, to a bellyache, to needing surgery, it's all one doctor. So they come here and they find that there's all these specialists. I mean, a specialist for gastro, a specialist for orthopedic, a specialist for everything, even for pediatrics, where before, where they come from, typically it's just one doctor. And also they go when there's an illness and not necessarily for preventative care. There's no annual checkups. They go when there's something acute happening. And so then the concept of having a primary care physician just for a checkup can be a little foreign. And I've seen that very, very frequently, where when they're asked who their PCP is, and you have that glazed look in their eyes because they never even thought that that was something that they needed to do. So they'll go to their oncologist and go in for anemia, and then they'll ask, by the way, my stomach was upset and I have a scrape back here on the back of my leg, if you can take a look at that. And the doctor's telling them, well, you need to see this doctor, that doctor, and this doctor. And it's a very foreign concept. So that's where they need to be explained. It needs to be explained that there are different doctors for different specialties to take care of them properly. I've seen a lot of patients who don't ask questions, and it's disappointing because I think there's so many questions to be asked when you're given a diagnosis or you're told of a treatment plan or you're told of what, you know, options you have. And often there are no questions asked because they just trust the doctor that much that it's just, if the doctor says so, we'll just move forward. Um, so there's no questions asked. Later on, sometimes they'll ask me, and then I have to go back and bring the doctor back in and say, there are questions. But it's just a cultural thing not to really question the authority. Next. This is very unique too. Maybe not so unique nowadays, but when you start a conversation, um, many Hispanics like to have a little small talk and not get to the bottom line right away. It's just a way of easing into the conversation to build trust and security. And so many clients that I've come across want to have that conversation ahead of time. And it could be anything, where are you from, or what did you do today, or, you know, tell me about your family. It could be something very similar or to that. And they just want to have a conversation to get to know you, to get to feel comfortable with the community and with the setting that they're in. And it's just a comfort before they get down to business. Metric versus imperial. We use imperial system, of course, and I've had a lot of patients who get on the scale and they want it converted to the metric system for their weight or for blood pressure or whatever measurements being taken, the temperature. It's something that they're accustomed to if they have not been here very long. Um, I'm seeing more and more that a lot of patients are becoming more accustomed to the imperial system, but still once in a while I see a lot of patients who still want to use the metric system and will ask specifically to have their temperature or blood pressure or whatever it is converted to metric so that they have a better understanding of what their numbers are. Um, so that's just something to keep note of. Uh, it caught me by surprise the first time I saw that because I never grew up with the metric system here. Um, but it's just something that they're accustomed to. Concept of time. I really think this goes beyond the Latin community. I've seen it in a lot of foreigners that the concept of time is not relevant. So patients arrive late, whether it's a party or an appointment or or even catching the bus. It's just for some reason a cultural difference, that time is just not important. Walking slow, enjoying the breeze, smelling the flowers is more important than getting somewhere on time. I've had this happen many times, sitting in a waiting room, waiting for a patient to stroll in, because time is just not of the essence. I've had to call patients and ask if they're still coming, and they'll say, oh, my appointment's at 2. What time is it now? Oh, 2:15. Oh, okay. I was just getting dressed to leave. So it's just not that important. So if time is very important to your office, then you need to make that really clear, is that if your appointment's at 2, you need to be here by 2 o'clock, and stress that, because to them, 2 o'clock means 2:15, 2:30, unless it's stressed. 2 o'clock is 2 o'clock. Prenatal and postnatal care. Epidurals and breastfeeding. Epidurals, again, just like modern medicine and prescriptions and so forth, is more of a foreign topic. It's not considered natural. It's different. It's not something that is common where they're coming from. I think that it's more of an Americanism to use epidurals. I haven't heard, and I may be wrong, that it's been used elsewhere. When I gave birth to my children, my mother's aunt, my grand aunt, convinced me to not do the epidural. She told me, give birth naturally, experience the whole pain, everything of your childbirth, and you will be thankful later. And I actually did. So again, it's a cultural nuance that even was passed along to me, where I didn't do the epidurals for my childbirth. And I'll tell you, it was really painful, but I was the only one on the floor walking after birth. But it is something that's very cultural, because epidurals are just not a common thing to do when giving birth when you're not from this country, especially more recent visitors to this country. Breastfeeding is really more of a socioeconomic need. Sometimes breastfeeding is always best, in my opinion, but a lot of Latinos work and have to work when they've recently arrived. And so it's just not an option. And so pumping is not an option, and it's very foreign. So they will just revert to formula, which is very common, and nothing wrong with it. Um, but it's more of a socioeconomic need, and it's just something that is not seen as unnatural. When asked, are you going to breastfeed or are you going to bottle feed? It really is dependent on whether they need to work, need to be away from their baby for long periods of time. And so it's just dependent on their personal needs. Not many have the luxury of staying home and breastfeeding, and pumping isn't really something that's very common. And storing it is just another step that is just not very common to do. Next. Oh, that's it. So I guess, yeah, we
And
mistimed it, but I am open to any questions.
and Amy, I'll just, if I can just step in and add in a few
Mhm.
things in support of what you were saying. Um, so first of all, with regard to epidurals, I believe Anastasia may have shared with you a few resources that we sent you that shows that provides results from different studies that have been done and shows the discrepancies between the use of epidurals. Thank you, Anastasia. So the use of epidurals in Latino or Hispanic culture versus versus like in America, for example. So there's some good, there's a nice one pager that kind of summarizes, there's been many studies done about this, and you consistently see much lower use of epidurals among the Latino community.
Mhm.
Um, and just, yeah, echoing what Amy said, beside it not being very common in Hispanic or Spanish speaking countries, it's also a trust thing. There are definitely patients who don't um, they don't trust it. They don't, it provides them with sort of a layer of stress, or an unknown that they would rather not, move forward with. So I wanted to just touch on that, and then also a few other things just to support what Amy was saying. When you are, Amy was talking before at the beginning about the last names. The most Hispanic patients, and if they've been in the United States for a long time, they will be accustomed to hearing their last name being called as the second last name. So let me just share this. So, and I don't know if you can see my pointer here, but I can maybe,
We can see your pointer.
okay. So a lot of them, if they've been here for a while, they will be used to people saying, oh, coming into the waiting room and saying, Mr. Rodriguez. However, if you have a patient that's newly arrived in the Hispanic community, the father's last name is like the main one, if you will. So you might not, if you come into the waiting room and say, Mr. Rodriguez, you might not get a response, because for Jose, his name is Senor or Mr. Hernandez, not Rodriguez. So we see this a lot, that the nurses will call by the second last name, but that's just one thing to keep in mind, that if you do see the two last names, and as interpreters, when we address the patient, we'll always go up and say, hey, Mr. Hernandez. We don't ever say Mr. Rodriguez, because we know that's not how that person will identify. Principally, it's with their first last name. And then just to another point on this is why you see that children have different last names than their parents. So that can be a little bit confusing, I know, but this is why. And if you look at the names, you can see that the relationship, and now you understand the relationship here. But this is why you're seeing that Jose has a different last name from his parents, which is very unusual for us here. So
I have a
yeah.
question. If they're married, why does the mother not have the husband's last name?
Do you want to answer that, Amy, or do you want me to?
Because, sorry.
They do have the last name, but their mother's name comes after. So, for example, Maria Rodriguez Lopez. Wait a second. I see what you're saying.
Well, they would take. Sorry, go ahead, Amy.
No, go ahead. Go ahead.
And there was someone else here who I think wanted to make a comment on that. Feel free to speak up.
Just say,
Monica.
yeah. When you get married in our culture, you are part of the family, yeah, but you are keeping being part of your family, not that your family's husband. So, yes, maybe it's weird for Americans, but the rest of the world is not weird. You keep your name, and many new young people in here is not taking the last name of the husband anymore. So. Mm-hmm. That is why.
Yes, thank you, Monica. But you'll notice that when in most cases, when they put the name of the kid for their child, the child is taking you do see the father's last name being transferred over to the child.
But in that slide, is there a way to see that slide? Because I can show you another thing that I've seen a lot when they get married. And is there a way to see the slide again? I can.
Yes, give me 1 second.
The one with the family. So what I have seen, adding the name with female patients, I have seen Maria Rodriguez Lopez de Hernandez, meaning she belongs to Hernandez. She belongs to her husband. I've seen that also added.
I see it too in the Mexicans more than the rest of the South America, but yeah, they does.
Mm-hmm. Yeah, it's confusing, right? Hopefully this clears it up a little bit. But again, you can, I mean, there's always asking too, just asking the patient, like, what do you prefer to be called? Right? And not just making the assumption that this is the last name and this is the middle name, right? And then one other thing I wanted to say, just to add on to what Amy was talking about, specifically with medications, because I feel that this is just so important. Excuse me. You know, as I would just say that from the perspective of an interpreter, when I'm in a consult with a patient, if the nurse who's admitting the patient asks the question, are you taking any medications? I, as the interpreter, will always chime in and say, this is the interpreter speaking. Would it be okay if I ask the patient, are you taking any medications, herbal remedies, or supplements? Because, and so it's good to be really clear with that question when you're asking patients, because it is possible that they are taking something that was sent from Mexico by grandmother. I've seen patients who are taking grape extract, who are taking different teas, like tea mixtures. And so it's important to ask that question very specifically and very directly, because potentially they're going to say no, but actually they are taking a tea that could interact with the medications that you're going to prescribe to them. So I would try to be very specific with that question, knowing that there's the potential they're also taking something else in addition to prescribed medications that they may or may not be taking.
And then I do see Monica's hand up. Monica is the Strong Starts lead community health navigator for Niswanger. So Monica, go ahead.
Yes, hi. In not only the last name is a big problem in the birth certificate world for our patients when the baby is just born. When they do the birth certificate, the big problem that we having is the dates, because in United States is the only place in the world that we do month, day, and year. Europe and South America is day, month, and day.
Yeah.
So sometimes we had to take 6-7 months from vital records can change the birth certificate of the kids, because no match the parents are not the parents in the papers for our kids.
Oh yeah.
So that is something that we really had to ask with the, with the date of birth, like a 5/6/2000. No, it's the 5/6 or 6/5 of 2000.
Right. So just keep clarifying to make sure everybody's
Yes.
on the same page.
Yeah,
Yes.
that happens a lot when filling out forms as well. Just making sure that you're clarifying.
And I've also come across a case when it comes to medication, the importance of having bilingual, like say pharmacists, community health workers, or just providers, for the simple fact that a mother, when she read the medication, she saw once. But of course, that's 11 in Spanish. And so instead of taking it once a day, she was sitting there trying to give it 11 times. And that was an issue as far as, the child almost died. So I just noticed that, it's very important that people discuss, like I said, action plans, medications, or whatever the case may be, so that is a clear indication as to what's required of their care.
Absolutely.
Mm-hmm.
Monica, did you have any other pieces of advice specific to labor and delivery, postpartum, NICU, or infant setting?
Well, we have many stories, but moms are not willing, the typical questionnaire that they say, oh, how you feeling after postpartum? How you feeling? You need to speak with somebody, and they always say no. It's so rare that a Latin woman say, yes, I need to speak with somebody the mental health, because for them it's like, oh, I'm not crazy.
Mm-hmm.
And they don't know, or they don't know the different, or the moms are in the room and the moms, so they, no, my daughter will not take this. uh, that is very, very difficult to explain. They need maybe somebody to help you. And I many times I had to take the mom, I say, hey, no, maybe the hormones, and go another way with the mom, for the nurse can actually asking how they feel. That is one thing. Birth certificates is a big discussion in the family. Names, uh, people the second generation in here, they only put one last name. Family get mad because they don't have two last name. Many things are they're funny for us because we not living the situation, but we had to take serious that things when there's family involved. So it's very critical what the grandma, aunt, uncle, cousin, that we really we don't have that kind of relationships in here, but for that it's very important. And like Amy say, when they go to the doctor with the more than one people, the decision is a family decision.
Thank you, Monica. And I saw Naya, you had your hand up.
I did. Sorry, I was having some issues with the button. So yes, my name is Naya. I'm with Healthy Birthday, the organization that's created with Count the Kicks. And we work with moms and expectant parents and providers around making sure they know what's normal for babies around counting babies' movements, and once they find out what's not normal for their babies, notifying their provider right away. And something that I was really interested about in your presentation, Amy, is that piece around the Hispanic community and Latino community sometimes maybe not being comfortable about asking questions. And so I'm wondering, as we're encouraging patients to notifying their provider right away if something's not normal, what that would look like in advocating for themselves in the patient room. So we have an app called Count the Kicks, and it's completely free and available in over 20 languages, including Spanish and Haitian Creole and a few other different languages as well. And I'm just curious, I'm just curious about continued conversations about that advocacy piece. A lot of our patients or people who use the app have doulas and things like that, but yeah, I'm just wondering about what that might look like or how we might continue to have those conversations within the Hispanic and Latino community as we talk about counting kicks and stillbirth prevention within the Hispanic and Latino community in that way.
Okay. You want me to answer it?
Oh,
Okay.
yes, please.
Yeah. Well, I have found, as I've talked to a lot of clients and knowing from my personal experience, is that in the American medical community, there is a lot of emphasis on details, like counting kicks, counting this, making sure this is going on. And typically in the Latino community, it's more intuitiveness. It's how you feel. Are we okay? There's not as much stress on these little nuances and details. So they may not ask questions because they are intuitive more about how they feel. And they may ask a mother, an aunt, what was your pregnancy like? Was this normal? Was that normal? Rather than calling a doctor or a nurse or whatever, they stick to their own family as their advocate, as their resource for how they feel and what to do next. So that's just something very cultural. I think that is just something that you would have to be very cognizant of and just communicate more what you're looking for, in terms of what the expectation is from the patient. You know, we want to make sure that everything's okay with your pregnancy, and we're looking for the number of kicks per month or minute, or, you know, and explaining how that exactly looks like, so they can practice it at home. But typically it's really based on intuitiveness and your own family history, and asking mom and aunts and grandma.
Thank you for that. And to clarify, Healthy Birthday, we're at education and materials. We're not like a healthcare institution. So we
Mhm.
provide those materials to
Mhm.
providers and expectant parents.
Mhm. That's very cool.
Yeah.
Very nice. Thank you.
Thank you for your answer. I appreciate it.
Mhm.
Thank you, Naya. Great question. And then Gloria, I saw you have your hand up.
Yes. So I work with the femur group here in Nashville, and I just wondered if one of you could speak a little bit about how the Latino community views grief, especially we deal with stillbirth and infant loss. So just ways that we can be mindful culturally with how they might express their grief, but also how they view miscarriage and stillbirth.
Okay. Do you want me to answer? Okay. Well, again, they fall back on their faith. Definitely. That is a huge, huge part of their lives, is falling back on their faith, and um and family, really. So it is a little bit different, where what I've witnessed is that an Americanism is more looking outwards for resources, where the Latino community looks inward. They look to their family very much, for resources and for support. That's just a cultural nuance that the Latino community has. Um, Typically, Latino families are very large, so they have a huge amount of resources, extended family that they go to for those resources, and they do not tend to look outward. I don't remember if it was Monica who mentioned it about therapy. Um, Therapy in the Latino community is looked at as something you do if you're crazy. You know, you go to see a therapist if you're nuts. It's not someone you go to express your feelings or talk to. It's just seen very differently. And I have sat in some of those therapy appointments to interpret, and I always have to preface and explain to the therapist to please explain the purpose behind sitting there. It's not because she's crazy, it's because she needs to talk about her feelings and her emotions, because she's going through a difficult time. Um, because it, the patient really doesn't know why they're there. They think the next step is going to an institution. So, but grief is handled almost always within the family, rather than going outside. Does that answer your question? Yeah. Yeah, it's a hard one. It's a hard one, because you want to reach out and you want to be there for them, but it's just they're uncomfortable.
What in my experience, what I normally do with the moms that have miscarriage in my caseload is connected with. I find out if the family go to some kind of church, normally Catholic, or if they go to some church, connect with the pastor or with the priest. And it's the best way that you can speak and they trust to these people, you know, to recommendations.
Mm-hmm.
If I have some mom in the caseload for more than 2 or 3 months, yeah, I will go and suggest things. But if no, I will not take that step because they will hang up the phone on me.
Yeah, typically if you suggest we have a therapist that we'd like you to talk to because you lost your child or whatever, typically you'll get that glazed look and they'll say, why would I go to a complete stranger if I have my aunt, my grandmother, my other aunt, my mom, my other aunt, my uncle, my dad, my cousin, my, huge amount of extended family to talk to. So you'll get that glazed look and wonder why you're sending them to a stranger.
So some of the families, we actually try to interview our families with loss. And so this has been really helpful too, because I think that'll help even when I have an interpreter to kind of actually be able to communicate better with them. But sometimes they don't have a lot of family here, depending on how long they've been in. So I don't usually say therapist. I usually talk about a counselor to help them just talk about their grief. Does that help just to kind of frame it that way, to just say to talk about your grief and to be able to have someone just to talk to?
Yeah, I suppose counselor, therapist, they may see that as the same thing. Um, there has to be a trust relationship built, versus having someone outside of introducing someone completely new after the loss. So there has to be some trust built, that small talk conversation, that introduction that has happened for a little bit before someone can feel comfortable expressing their feelings.
So it would be good even for me to be able to be the start and then a couple of months reach back out, because I've then developed at least a bit of a relationship to possibly then introduce something and to make sure that they've have someone they're talking to. And if not, then maybe offer something as far as like, okay.
Definitely, if you have a good connection, sometimes it's just start for the mom or for it's much easier if they believe or a friend of them have some relation with you, a good experience with the organization that you work, they will be most trust you and trust what is the process.
Somebody also asked, and this kind of relates to what we do in FEMA, but they asked about safe sleep and how families feel and as far as providing that education. So if you could even just touch on that briefly before we run out of time, but like the Hispanic community and Latino community, their views on safe sleep. And I know lots of times co-sleeping is very common in their culture. Is there ways we can educate and help with that?
I think it's just a matter of communicating the importance of, what you're trying to express, what you're trying to teach, and giving the reasons for your specific request. You may get through, you may not. In my case, didn't get through. So it really is just a matter of how you get through and how you educate the person on your reasons for what you're trying to express. That's a tough one.
Yeah, the reason why I asked that question is I currently sit on Cribs for Kids National Advisory Board, and that's something that we're trying to do is create educational material that also acknowledges traditions, religions, cultural, appropriateness, and like you said, it's just a matter of presenting the evidence-based information, but also honoring body autonomy and how families choose to raise their children. So that was the reason why I was asking, because specifically while I have, y'all on the call, it's like, okay, how can we, get to these families? But like you said, also not, not, step on any toes, because it is, like I said, a cultural practice.
Right, right. And so, education is really key. But the bottom line is really, I think culture sometimes trumps education. It's just, we go back to intuitiveness, what we feel, what we've grown up with, what we've learned from generation to generation, how we've seen our families growing up, and then we emulate that.
I like that. Sometimes culture trumps education. I like that.
Well, this is an incredible conversation, and I really appreciate everyone's engagement, and Jenna, Amy, and Monica's input. Um, just the tip of the iceberg here. Definitely could have a full series on this. So thank you all
Sure.
for your expertise. Um,
And Anastasia, if I could just say one thing.
oops, yes. Oh, you muted, Jenna.
Sorry. I just want to say one quick thing. I put my email in the chat, and I invite anyone to send me an email. So we don't have a lot of time to answer questions, but Naya, if you want to send materials and for us to see what that looks like and provide some feedback, or it please don't hesitate to reach out, and I will do my best to help answer any questions that you have, because this work is really important that you're doing, and very much open and available to help find answers to any of your questions.
Thank you, Jenna. And with that, I will turn it over to Bonnie to close us out with some upcoming events and closing announcements.
Thank you so much. Thank you all for such a great talk. I was getting tons of text messages talking about how much they love this talk. So thank you. Next slide. What are we coming up? Coaching calls. All teams, we're asking you to schedule a coaching call with TIPQC in November. Gather your full team's ability, how many people you can, schedule a time with Anastasia, and let's get something on the calendar. Next. The SMM case review webinar is the 20th at 12 p.m. CST and 1 p.m. EST. That's where our severe maternal morbidity case is reviewed by a maternal fetal medicine specialist. Next. Save the date for our TIPQC annual meeting, March the 24th through the 26th at the Marriott Cool Springs, where we normally go, and be excited to be there. Thank you so much for that. Next. We want you to submit your abstract highlighting your QI work to the TIPQC annual meeting, which is in March. The sessions open up to maternal, infant, joint, maternal and infant, or health equity QI work that your team has completed. It does not have to be a TIPQC project. Abstracts are due by January the 12th, 2026. There is a template for the abstract will be provided. Feedback will be given on each abstract by experts in that area so that the feedback can be incorporated into the actual poster. All submissions will be on the TIPQC website, and winners invited to attend in-person poster session at the annual meeting on the 25th. Top projects will be highlighted during our meeting. This is an opportunity to share your great work with others. Next. And don't forget, we're going to say that again. We're going backwards. Also, homework, the next hurdle. You have homework on December 11th. Schedule a coaching call with TIPQC. So our expectation is that you have one at least scheduled, so we can report off saying we've scheduled one. And then register for upcoming trainings. I want you to keep calm and mark your calendars. I know it's the holiday season and we all get, real busy. But if you can schedule that coaching call, we'd appreciate it. Next. Your Simple QI website has all the project resources. Please, please, please utilize that. And if you have any questions about it, let us know and we will help you. Next. And then here's our post-huddle survey. Scan that and let us know how well we did, if there's anything we can improve on. And I think there's probably comments where you can say, we would like to see this. But most of all, I want to say thank you all for showing up and showing out and across the state, making lives better for our moms and their babies. And thank you to our guest for a fantastic lecture. We so appreciate all of the input, all the questions that everybody had, and the answers that went with it. It does make everybody's life so much easier when we all understand everybody. That's why it's best for all. Thank you so much for everybody for attending. Have a great day.
Thank you, Bonnie.
Thank you.
Thanks, everyone. Have a good rest
Thank
of your
you.
day.